Okay, this is the first in the series of videos on coronary anatomy. So let's go ahead and get started. What you're looking at here is the anterior and posterior aspect of the heart, and the major arteries are already drawn in red, as you can see, and we're going to label these as we go. So let's just start right here at the aortic arch, and imagine if you could slice this open right here and then look down, you'd be looking at the aortic valve, which here is composed of three cusps: the left coronary cusp, the right coronary cusp, and the posterior coronary cusp. Right above the left coronary cusp starts the left main artery, which is the left coronary artery's origin. So I'll just put LCA right here. Right above the right coronary artery is the origin of the right coronary artery. So I'll just write RCA right there. There's no vessel that comes off above the posterior sinus, so it's also known as the non-coronary cusp. So now let's travel out to the anterior aspect of the heart. This big vessel right here, that's our left main. So I'll just put LM right there for left main. The first vessel that kind of comes out on the lateral edge here and travels around even to the posterior edge of the heart is called the left circumflex. So I'll just put L circ for short. That's kind of its nickname, the circ. So that's it right there. We're looking at it on the other side as well. The rest of the left coronary artery is composed of this big vessel called the LAD, the left anterior descending artery. So I'm going to put kind of LAD right here. Each of these vessels, they have another set of large vessels that come off them. Usually the big vessels that come off the left circ is this one right here. It's called either the left marginal or the obtuse marginal artery. So let's write obtuse marg for short. And then vessels that come off the LAD, kind of the next in size, usually travel about like that, and they're called diagonals. So I'll just write diagonals there. One defining feature of the LAD is that it provides blood flow to the anterior part of the septum. And usually on angiography, you can see these very fine vessels that sometimes look like this that are called the septal perforators. So let's just write septal perforators. And one learning point I remember being taught is that if you're looking at an angiogram, the best way to identify the LAD is to find the big vessel that has these little septal perforators that are easily identified. Just one little tip. So now let's look at the right coronary artery. Here it is on the other side. It wraps around the right side of the heart. So let's just label it RCA right here. Branches that come off the RCA and travel like this are also marginals. They could be called right marginal arteries or acute marginals. Okay. And so the right coronary artery, as you can see, it wraps around to the posterior aspect of the heart, and it provides blood flow to this large artery, which is called the posterior descending artery. Let's just call it the PDA to be short. And this vessel will provide blood flow to the posterior aspect of the heart and the posterior septum as well. Just by convention, we define whatever vessel provides blood flow to the PDA as the dominance of the heart. So If the PDA gets its blood supply from the right side, we call it a right dominant heart. If it gets its blood supply from the left circumflex, we call it a left dominant heart. And if it gets its blood supply from both, we call it co-dominant. Apparently this happens about 85% of the time, maybe. People are right dominant. We've seen different things, 10 or 15% are about left dominant, and maybe 5% of the time or even less, you'll see co-dominance. One other tiny vessel that we should bring up, there is a SA node artery that sometimes comes off this the RCA right there. I'll just say SA node artery. And this is a small vessel that provides blood supply to the SA node, which is the area of the right atrium that actually sets your heart rate. So we'll put it right there. Blood supply to the SA node, usually about 60% of the time it'll come off the RCA, and about 40% of the time it comes off the left coronary artery. But it sits right there. That about does it for this initial video. We'll move on to more in the next video. Okay, so this is the video 2 of the series on coronary anatomy. What we're looking at right now on this side is a coronal view of the left ventricle. And this is another view over here showing you the left ventricle and the right ventricle side by side. What we're going to focus on real quick right now are the papillary muscles. Coming from out of the papillary muscles are the chordae tendineae, or the heartstrings. These are just collagen fibers basically that connect to the mitral valve up here in this case, such that whenever the heart contracts, the papillary muscles contract. There's a lot of tension on the cords here, and it'll hold the mitral valve closed so that blood does not go back up this way back to the lungs, and it actually goes out the aortic valve, and then to the rest of the body. So blood supply to these papillary muscles is kind of interesting, and it's clinically significant. So this one right here is called the anterolateral papillary muscle. So let's just write anterolateral. And it actually gets blood supply sort of from two sources, partially from the LAD, even some from the left circ. So this is useful to consider in that there's actually collateral flow here. So let's say one of these vessels gets knocked off, at least you have the other one providing some blood supply to actually perfuse this muscle. On the other hand, we have this posteromedial papillary muscle. So let's run it here. Posteromedial papillary muscle primarily gets its blood supply from the PDA, that posterior descending artery. So it's more dependent on blood supply from one vessel. So you can imagine a situation where if the PDA gets knocked out, blood supply gets knocked out to the posteromedial papillary muscle. But if you actually had necrosis in this papillary muscle right here? So now what I've shown here is, what if this papillary muscle has necrosed and all the chordae tendineae are ruptured away? You would then have a regurgitant mitral valve right here. So this insufficient mitral valve, now whenever the LV contracts, blood can easily flow back across this flailing valve. And clinical consequence here is that with a MI affecting these areas as I've described, you have pretty bad mitral regurgitation which will just contribute more to pulmonary edema and worsening clinical status. Also, it's worth mentioning a few things about the cardiac veins. So I've overlaid the veins here in blue on top of the arteries, which we've already gone over. A couple things worth pointing out. This big vein right here is called the great cardiac vein. As you can see, it's going to drain up and it drains around the lateral edge of the heart into this large structure called the coronary sinus. Right here we have the middle coronary vein, which is draining in the same direction up to the coronary sinus, which we'll go ahead and label. There's a small cardiac vein that drains into the coronary sinus as well. Coronary sinus is this large venous draining system that drains right into the right atrium, which is right in here. And of course, after all this drains into the right atrium, it's going to go down to the right ventricle and continue the cardiac cycle. Something else worth mentioning, these are anterior cardiac veins. And they are different because they really just drain directly into the right atrium. I mean, they're right there. They might as well just bypass this whole fuss and drain directly, and that's exactly what they do. That's really pretty much all you need to know about the venous drainage. Uh, Not as clinically significant as the arterial supply, but worth noting as well. That's about it. Okay, so this is the third video in the section on coronary anatomy, and so now we're going to correlate myocardium with the EKG. So you should be familiar already with the EKG and the leads as I've set them up, but just to briefly review, remember leads 1, 2, and 3 are bipolar leads. And basically, think about it this way. Lead 1 considers the left arm to be positive, so it's only going to look at voltage changes from the perspective of the left arm compared to the right arm. Lead 2 considers the left leg positive, so it's only going to look at changes from the left leg's perspective with relation to the right arm. Lead 3 considers the left leg positive, and it's going to monitor changes compared to the left arm. Likewise, there are these augmented limb leads. There's AVL, which is only going to see changes from the left arm's perspective. There's AVR, which is only going to see changes from the right arm's perspective, and then AVF, which is only going to see changes from the legs or the feet. That's why we call it F. Another set of leads that we deal with are the precordial leads, V1, 2, 3, 4, 5, and 6. I know that 5 and 6 are kind of on the lateral edge of the chest, kind of right in the mid-axillary line, but just to make the drawing easier, I kind of laid them out like this, but imagine these really wrapping around the body a little bit. These are leads that are sitting right on top of the heart, right on top of the left ventricle, wrapping around to the lateral side. And so they're obviously going to be sensing voltage changes directly beneath them. So knowing all of our tools here in the EKG, it's important to know how myocardium can be directly sensed by certain EKG leads. And that's really what we're going to cover right now. So we only focus our attention on a few uh, large areas of myocardium. Here they are. So one, the anterior septum. So that is one territory. So imagine it's sitting about right here. So V1 and V2 are pretty good leads for identifying uh, what's happening at the anterior septum. Next, the anterior wall of the LV, that is. What do you think would be the leads that tell us what is happening at the anterior wall? Well, I think it's probably safe to say V1, probably V1 all the way through V4. It's pretty good. Some of it may even stretch over to V5 and V6, but V1 through V4, pretty solid. What about the lateral wall? So think about this. Now we'd have to think about what leads are really good at action happening on the lateral side of the heart. So lead 1, AVL, and then lead V5 and V6. Those are considered lateral leads. What about the inferior wall? Classically, these are lead 2 and lead 3. So think about it. Remember, they consider the feet to be positive, and so they're going to sense voltage changes in relation to that. So 2, 3, and then AVF. These are known as the inferior leads, which is easy to understand. All right, so we've covered all those. What about the posterior wall? Hmm, that's kind of tough. Well, some of the tricks, you could look at the inverse of V1 and V2. If you think about it, if V1 and V2 are acting normally, what if you saw ST depressions? That could actually indicate ST elevation at the posterior wall. So the inverse of V1, V2 is could hint at trouble at the posterior wall. Or if you're really suave and you pick up something, you can actually order uh, just a posterior EKG, and then you can interpret it correctly by recognizing any ST changes in relation to that posterior wall. What about the right ventricle? Well, I hope you're realizing pretty much all of our leads are really biased towards the left ventricle. I mean, again, I guess it makes sense. It's the pretty important. It gets a lot of blood supply, gets a lot of blood flow, and um, problems ensue when it infarcts. But the right ventricle can be involved as well. Um, there are a few things you can do to evaluate the right ventricle. You can order a right-sided EKG with the leads basically flipped on the other side and interpret that correctly. But also remember the PDA, about 85% of the time will come off the RCA. So most people are right dominant. So if someone's having RV involvement or RV infarction, you're likely to also see changes in those inferior leads, 2, 3, and AVF. But the tricky thing here is really we don't always get a great look at the RV, and we don't always get a great look at the posterior wall. Um, So you can do these kind of extra things, but you do have to specify with the EKG tech. The other areas of the heart we capture pretty well through most of our leads. Okay, so here's our fourth video that hopefully ties everything together for you. What I'm showing you is I'm going to show you ST elevation in different parts of the EKG. And based on that, I want you to be able to predict where the infarction is occurring in terms of what territory of the heart. And then based on that, I want you to be able to predict what vessel likely had the acute thrombosis as a result of plaque rupture or whatever would be causing the MI in this setting. So here you are reading your EKG, you see ST elevation. If you saw ST elevation in leads V1 through V4, okay, so what characteristic myocardial region would that be? Hopefully you're saying that's probably anterior, an anterior MI. Based on that, what is the most likely vessel that's occluded? Probably a LAD lesion, the left anterior descending. All right, now what about if you saw ST elevation in lead 1, AVL, and V5 and V6? What territory is that? That's lateral wall. So that person could be having a lateral MI. If you saw that, what do you suspect would be the vessel? I'd say probably the left circ. That'd be a good guess, the left circumflex. All right, but what if you saw ST elevations all across V1 through V6, and then you also saw it in lead 1 and lead AVL? What would you call that? An anterolateral MI? Yep. And based on that, what vessel do you think? Well, I mean, think about it. You're affecting a large amount of territory, anterior wall and lateral wall. I mean, they could have a left main down or proximal LAD. Or maybe they're just unlucky and they have both the LAD and the left circumflex down. Any combination of these would make sense, but this is definitely the EKG that would get any cardiologist pretty excited. Okay. What about leads 2, 3, and AVF? I hope you're saying inferior wall. That makes sense. Vessels, so either the RCA could be down or the PDA, posterior descending artery. Now what about leads V7 through V9? So you're probably saying, what's that? Remember how I said you could order a posterior EKG? They can just continue to wrap. They can place more leads after V6. They can continue to put these precordial leads around the posterior side of the chest, and makes sense. You just keep numbering them higher, after V6, V7, 8, and 9, and you just wrap those around to inspect the posterior wall. So if you see ST elevation and a posterior EKG or posterior leads, I hope that's not too difficult for you to come up with. That could indicate a posterior MI. Culprit vessel there, probably the PDA, but could also be the RCA as well. One kind of characteristic clinical picture you could see, usually think about it, if you're having an anterior lateral MI on the left ventricle, you're knocking out the main pump. This group right here, these are the ones that are going to have pump failure, cardiogenic shock, and pulmonary edema. That's what you want to look out for in this group. This group over here, so if you're knocking out the RCA and the PDA, you're knocking out the posterior wall and the RV, um, they tend to have predominantly right heart failure. They could have hypotension, uh, cardiogenic shock as well, but also remember there's that SA node artery. What if you knocked that out? That could cause bradycardia. So there you have it. I mean, it's not going to happen every time. I'm not saying um, this will always occur, but just a couple of different syndromes you could see uh, with these different patterns of myocardial infarction. And that concludes our series. Hope you enjoyed.